Hi, I'm Mark Sabatine, chair of the TIMI study group. And in this edition of From the Chairman's Corner, I'm delighted to welcome Dr. Erin Bohula, one of our investigators here. We're going to talk about VESALIUS-CV. Erin, VESALIUS-CV, TIMI 66, presented at a groundbreaking clinical trial session at AHA. And it's not just me saying that. That was the title of the session that they put your trial in. And really, Vesalius was the capstone of a fantastic session. The data you presented were incredibly well received by the panelists, by the audience that erupted into applause several times. So thrilled with what you showed. And the simultaneous publication in New England Journal. Mm-hmm. So congratulations for that. Just a tremendous, tremendous feat. Before we get into that, I want to turn the clock back. Mm-hmm. Turn it back to 2012, I think, when you first joined us here. Mm-hmm. And one of the first trials you worked on was Improve It. Mm-hmm. Right? So you already had some experience with adding a non-statin to a statin. Yeah. That worked out well and then presented 2 years later in your hometown of Chicago. That's right. At the AHA. Mm-hmm. That same year that you joined us, Bob Giuliano presented the results for Laplace TIMI 57. Right, that was the dose-ranging trial of evolocumab that set the stage for Fourier TIMI 59, which was a great trial, if I don't mind saying. So, it's fair. Showed the benefit. The first trial showed clinical benefit of a PCSK9 inhibitor. It showed the safety. It showed the benefit of getting LDL cholesterol down to about 1 millimole per liter. There's one thing we would change in the trial. It was the duration of follow-up for the patients. We had planned for it to be 4 years for reasons beyond our control. It turned out to be 2.2. You've thought a little bit about that issue. Just for our viewers, what should they understand about duration of therapy for lipid lowering?
Yeah, no, it's a really important point. We know that there's a lag in the cardiovascular benefit that's seen with lipid lowering therapy, and that it takes some time to sort of achieve that maximal benefit. And so the longer duration follow-up you have, the sort of more maximal benefit you'll see. And so a short duration trial will probably underestimate what would be a long-term benefit for that patient.
Yeah, and that was our view for it, but of course you have to sort of prove that. Mm-hmm. And the other issue for Fourier is not uncommon in this field. We start at the top of the risk pyramid. Mm-hmm. Looked at patients who had a heart event, a prior MI, a prior stroke, and symptomatic PAD, or been revasked for that. And so right after we finished Fourier, then that fall, we started working on the design for Vesalius. So that takes us to Vesalius. And at a high level, tell us what were the objectives for Vesalius to add on to what we'd already shown in Fourier?
Yeah, so two major objectives. The first was to take it down a notch in terms of the risk profile of the patients, to say, let's look at this agent, this PCSK9 inhibitor, in a lower risk population and see if we see cardiovascular benefit. And then let's also do this study with a longer duration follow-up to sort of match what was done with the statin trials, where we sort of learned about that lag in benefit and see if, in fact, we see something similar with longer duration follow-up.
And the statin trials typically ran how?
4 to 5 years.
Yeah. And so then you plan the same?
Yeah, our aim was to have a minimum median follow-up of at least 4.5 years in the study. So to sort of mirror what was done for many of the statin trials.
Perfect. And I suspect many of our viewers know, but just to remind them, PCSK9 inhibitor, how does that work?
Yeah, so evolocumab is a monoclonal antibody which prevents the binding of PCSK9 to LDL receptor, which the ultimate end game is that there's more LDL receptor on the surface of the liver. You get more removal of LDL from the plasma, so lower LDL levels.
Yep, perfect. Now you had mentioned you wanted to study a lower risk population. I know you and Bob and Nick Marston put a lot of effort into thinking about how to craft this population. Tell us about the folks that you aim to enroll.
Yeah, so at a high level, the Vesalius enrolled patients who had evidence of atherosclerosis, but who had not suffered a prior event like MI or stroke, or high-risk diabetes. And sort of in a little more detail, it could be patients with evidence of coronary disease, but without a prior MI, patients with cerebrovascular disease without a prior stroke, patients with PAD, or high-risk diabetes. And high-risk diabetes, we included patients who had evidence of microvascular disease or chronic insulin use, or if they had been diagnosed a while ago, so at least 10 years ago. And ultimately, the population had about 2/3 of patients who had one of those atherosclerotic disease states, about half who had high-risk diabetes, and about a third who had high-risk diabetes with no qualifying atherosclerosis. So that sort of high-risk primary prevention population. And then patients also had to have an elevated lipids. And so kind of the most commonly applied criteria was an LDL of at least 90 milligrams per deciliter or greater. And then there were sort of comparable elevations that could qualify with non-HDL or with ApoB.
Yeah, well, terrific. And as you described, the population sort of nicely spanning, if you think about both the US and the European guidelines, and the US guidelines talk about sort of very high risk ASCVD, which basically was 4A and obviously outcomes, they'd had a major event.
Yeah.
Then you move a notch down to those just with ASCVD, but not very high risk.
Mhm.
And the ESC guidelines similarly have that population, which they call very high risk. The nomenclature gets confusing. But then as you move down, then it's patients with diabetes. And certainly in the ESC guidelines, they make some distinctions between the risk factors for it. So patients with known athero, patients without clinically known athero, but with an important risk factor like diabetes. So that's great. And the duration, right? You wanted the median to be at least, you said 4.5 years, and what did it turn out?
Yeah, it was 4.6 years. So we definitely hit our goal there, which we, again, we're trying to mirror what had been done in the statin trial. So 4.6 years on median for follow-up.
Perfect. So maybe to tease the audience a bit more, let's just start with the lipids and tell us what happened to the LDL cholesterol levels.
Yeah, so the baseline median LDL in the entire population was 122 milligrams per deciliter. And we had a sub-study, a lipid sub-study. And in that group, the LDL median was 115 milligrams per deciliter. And EVO reduced that by about 55% down to roughly 40 milligrams per deciliter, which was approximately a 63 milligram per deciliter reduction. And that was at 48 weeks, and that was maintained over the duration of follow-up.
Yeah, great. And those LDL cholesterol levels, how do they compare to what we see in general practice for these sorts of patients?
Yeah, well, I mean, obviously, we enriched for a high LDL group based on our inclusion criteria. The other thing I should mention is that these patients, the vast majority of them were on some form of lipid-lowering therapy, including 2/3 who were on a high-intensity statin. So those sort of metrics were very good and much higher than what we see in sort of clinical practice in terms of the use of these high-intensity agents. And the LDLs in clinical practice, again, do tend to run higher than what we would hope for based on what our guidelines would suggest we should target in these populations. And so, our LDL is elevated, but I think that's sort of consistent with what's being seen in clinical practice.
Yeah, no, I think that's right. So these are the sorts of patients you and I might see on any given day. Okay, so then the trial had dual primary endpoints. Tell us what those were and what the benefit was of evolocumab on those.
Yeah, the fun part. So we had, as you mentioned, two co-primary endpoints. The first was a 3-point composite of coronary heart disease death, MI, or ischemic stroke. And the second was a 4-point MACE composite, which was the same elements plus an ischemia-driven arterial revascularization component. And what we saw was a 25% reduction in the rate of the 3-point MACE composite and a 19% reduction in the 4-point MACE composite. And just to sort of give a different perspective, that would be a number needed to treat for the 3-point of about 55 over 5 years, and for the 4-point around 35 over 5 years.
Terrific. So those are very impressive risk reductions, and really gets back to the point that you raised, right? That you need to let the lipid lowering effect take enough time to see that clinical benefit, which we did in VESALIUS. Now there were a whole bunch of other endpoints, different composites, different individual ones. Tell us about those.
Yeah, so we had many different composites. We had a testing hierarchy that included a number of composites, and then further down in the hierarchy, individual endpoints. And we saw significant reductions in all of the composites, including a 27% reduction in the composite of cardiovascular death, MI, and ischemic stroke. We observed a 36% reduction in MI, which is sort of a staggering finding. And then we weren't able to formally test cardiovascular death and all-cause mortality because of the testing hierarchy, but we still did observe nominally lower rates of both of those. So, for example, for all-cause mortality, the hazard ratio was 0.8 with a p-value that was nominal p-value of 0.0005.
Wow.
So also fairly compelling results
Yes,
there.
unlikely to be play of chance, given
So-
that yeah, and all-cause mortality does not lie. So that's quite impressive. And the massive reduction in MI, you're going to put the cath labs out of business,
I hope
right?
so.
With this,
Fingers
which
crossed.
would be a good thing.
Yeah.
Now you did mention in the population that it was a mix of patients who had qualifying athero and then those who had high-risk diabetes. Tell us about at least those two subgroups, how it played out for them.
Yeah, absolutely. I mean, we generally saw consistency across all of the subgroups, the key ones that we looked at. But very importantly, the one you highlight is, I think, is worth speaking a little more to, which is that, as I mentioned, about 2/3 of the patients had qualifying athero of some sort. And they had a consistent benefit along with those patients who had high-risk diabetes without qualifying athero. So that third of the population, which is again, that sort of, that high-risk diabetes patient population without any clinically known atherosclerotic cardiovascular disease. So consistency of benefit amongst those two subgroups.
Yeah, so even in the primary prevention population. So that's quite impressive. Now, you mentioned the design that you worked to try to make sure this would, if you will, sort of emulate some of the statin trials, at least in terms of duration. And with that, then how does it compare in terms of the clinical benefit per unit reduction of LDL cholesterol?
Yeah, so I mean, the CTTC, did the meta regression of the statin trials, as we mentioned, that were on the order of 4 to 5 years, and they showed that the magnitude of cardiovascular benefit was related to the absolute reduction in the degree of absolute reduction in LDL. And we were hypothesizing going into this that if we could match the duration of follow-up here, that we might see something similar, and that's exactly what happened. VESALIUS fell along the meta regression curve, which means that we saw that the magnitude of cardiovascular benefit was related to the absolute LDL reduction. Importantly, with this therapy, which is a non-statin therapy, again, a PCSK9 inhibitor. So really, was that what we had for the hypothesis and the reason for having longer duration of follow-up? And it is what, in fact, we saw.
Yeah, and it nicely validates the genetic studies which suggested that. But again, you have to do the clinical trial to be sure. Well, that's terrific. So then, take-home messages for our audience.
Yeah, well, I mean, I think there's a couple important ones. I think first, that we can prevent that first event with aggressive LDL lowering. So I think that sort of now is a mandate to us to try to do that. And I think that the message is really that what we should be doing is we should be continuing to aim low at earlier in the disease progression. So, getting that LDL down very, very low, even before they have manifest, ischemic events.
Yeah, no, it's a powerful story across that spectrum of risk, and then again, really reinforcing getting that LDL cholesterol down to levels we don't typically think about, but getting it down to about a millimoles is probably where we need to go. Well, congratulations, truly a groundbreaking trial that will shape clinical practice for many years to come. I know there'll be many important secondary analysis coming out. Thanks, folks, for joining us for this edition from the Chairman's Corner, and look forward to seeing you again soon.